but thanks for being here at the conference, and thanks for the important work that each of you does. Here in our profession, we don't often get the chance to always say that to each other, so thanks for what you do. I value sharing this profession with you. Those of you that are claiming Cs for the day, you've already heard that spiel. You'll get the survey. Make sure you fill it out. You'll be able to receive them within about the next 30 days. So without further ado, which seems appropriate to say since we're in the theater, is that I would like to introduce our speaker. Our speaker today is Dr. Arvind Datt. He is a psychiatrist and the medical director of addiction services here locally at Southwestern Behavioral Healthcare at Stepping Stone. So Dr. Datt, thank you for being here.
I was just going to ask you if you want to come move down a little bit so I can see you guys when we're talking. If you want to, it's okay. Just a correction, I'm not a psychiatrist. My background's family medicine and addiction medicine, but it's okay. I think family medicine is like 80% psychiatry anyways. But yeah, thank you guys for having me. So I think you guys are all very interested. I'll try not to keep this too boring with a lot of medical terms, but just as a breakdown, we're going to go over some of the prevalence about substance use disorders, background history, some neurobiology and anatomy. I don't know if you guys have a lot of questions. Feel free to ask a question if you have one. Just stick your hand up. And then we're also going to go over some of the ASAM criteria that we use. I don't know if you guys deal with that a lot. You do? Okay, perfect. And then we'll go over some what we call MAT, the medication-assisted treatments. And we'll cover some of the 3 FDA approved for alcohol, opiates, and then some off-label use for stimulant use. Okay, so let's get started. So I think my first question is that I like to ask everyone is, who here thinks this is a disease of the brain, substance use disorders, or do you guys just think this is a morally conflicted person? You can be honest, it's okay. I guess put your hands up if you think it's a disease. Okay, good. So I agree with you guys. And why do we say that? It's because when we look at the disease model for medicine, we look at an organ, something that's causing a defect to it, and we get symptoms of the disease. So a common example I like to use is diabetes, right? If we're looking at the pancreas, either something's caused an effect to it at birth and you have type 1 diabetes, or you have ate so much sugar that your pancreas is kind of burnt out and has lost, some sensitivity to insulin and its receptors. And then you get symptoms of the disease of type 2 diabetes. So if we look at the prevalence of substance use disorders, it's about 13 to 15% of our population has a substance use disorder, okay? So if we look at that, just for alcohol use, it's about, 135 million. Drugs in general, that's what that DUD stands for, is about 48 million. But when we look at other things like hypertension, that's 120 million people have high blood pressure, and about 40 million people have diabetes. So when you think about it, this is a pretty serious thing, right? It's actually higher, just even for alcohol use, compared to hypertension. And then just binge drinking alone, about 60 million people. And the other one that I find very interesting is the adolescent group. We have already 1 million kids between 12 to 17 drinking alcohol, and 2 million experimenting with substances. To me, that's pretty scary because your brain's not done forming until you're age 21. So that's where I also see a big component of this dual diagnosis with substance use, behavioral issues. The brain's already responding and changing based off these substances before it's even developed. So I think that's a big key, and I feel this is going to be a big field moving forward in the future. Uh-oh, I pressed something. So what are the other factors we look at? We look at genetics, developmental issues, behavioral, social, environmental. So we consider all of these things when we look at any disease model, right? We get our genes from our parents, what neighborhood we grew up in, regardless of socioeconomic class. I like to point out there, where are most liquor stores, right? They generally tend to be populated in a poorer area, right? Lower socioeconomic class. So I point those things out, and also I look at how many grocery stores are in those neighborhoods too, right? So we look at all these things and just see, is this a product of the environment? We learn our coping skills and a lot of behavior from our parents. So regardless of just your genetics alone, which there are some specific genetic studies, I want to bring that slide up, but they've linked certain genes to marijuana use, alcohol use, nicotine metabolism, that that actually we can test for. But I think that science is a little far-fetched and a little ahead of its time. But let's talk about substance uses in general. We normally induce a substance, right? We're just going to use it for one time. Let's say somebody has a drink. No big deal. It produced an effect. We expect that. Then we have misuse or abuse, where now somebody is actually drinking or consuming a substance to have the effect they were looking for, to be intoxicated, euphoria, whatever we're looking for like that. Addiction is the point, or we'll call it substance use disorder now. We can grade it, right? Mild, moderate, severe. We're to the point now where they're having changes in brain function, circuitry, learning. My biggest things I look at are dependency, whether it's a physical dependence, meaning they have withdrawal symptoms when they don't have it, or the psychological dependence, cravings and obsessive thoughts. Okay? So we'll go over here with the brain in a little bit more detail. But when we look at binge or intoxication, is a stage where somebody is actually looking to get the pleasurable effect. Like I mentioned here, the withdrawal negative effect, this is a big sign of physical dependence, essentially affecting part of the brain, which is the extended amygdala. We'll go over each part in case you guys have any questions about that. And then we have this preoccupation, anticipation of the substance, which is that craving or obsessive thoughts. I don't know if you guys like these guys, Pinky and the Brain. And I kind of put this slide up there because essentially the simplest way I can put it is that these substances are acting on our midbrain. And that essential part of our brain I kind of call like our caveman brain. And it takes over the other parts of the brain, particularly our prefrontal cortex. And that's where we're going to go into greater detail is why people are using substances, lose control, poor impulse control, they can't go to work anymore. At what point does the substance use take over their life, right? Some people say, oh, I'm a functioning alcoholic. I can go to work every day, but I still drink, right? So it's at this point we're going to look at now the brain, and we're going to focus primarily on the prefrontal cortex, the limbic system, which composes of the amygdala and hippocampus, our ventral tegmental area, and the nucleus accumbens. And the part, again, I was talking about the brain is this deep-rooted structure here. Here's our prefrontal cortex, right? So if we were to take a cross point and go right down the middle and across, we're going to hit this midbrain part, okay? So essentially, what does the prefrontal cortex do? It's our part of our brain for higher thinking, more executive function and planning, decision-making, problem-solving, self-control. We're going to a little bit more details of that. And then we're going to talk about the hippocampus, which composed in the limbic system, which is our learning and memory, right? That's why they say never cram for a test, okay? It's only effective for 24 hours. All that information doesn't get to be stored into your hippocampus unless you get good rest and good sleep, right? So we can't store memories effectively. And then we're going to look at our amygdala, which I just like to call our emotional memory. It trains our body to respond to any stressful emotion with whatever feeling we're having, essentially to protect us, okay? And then this ventral tegmental area, which is considering of all the dopamine cell bodies. So dopamine is the main neurotransmitter we're going to be talking about here. And I don't want to call it just a positive or a pleasure reward pathway, but to me it's a positive reward pathway. Everyone just thinks it's there for pleasure, but it's there for a few other things too that are essential to the body. So when we talk about this prefrontal cortex, I'm focusing executive planning. What does that mean? Planning an organization. So how many people are using substances can't get to appointments on time? They're missing work. They're missing paying bills, right? So these are the day-to-day things that we see, but they don't notice it, right? My boss is just giving me a hard time. I'm late the 8th time. Who cares? I still showed up, right? They're not understanding that you got to plan your day. You got to get here on time. There's a reason why you're tardy all the time, but they don't have that view yet. And then we're looking at problem-solving skills, right? Short-term, long-term goals. If you're so concerned about spending all your money on using substances, they're not planning ahead. They're not planning to pay bills, right? So they start falling behind on those things. It's not like they have a retirement plan. They're planning for their future. But even long-term goals, instead of renting this apartment, I want to own a house one day, right? So those are not even crossing their mind at all. It's just, I need to focus on all my attention on the substance. Emotional and social regulation. This is a big one we see here in our residential treatment center. When they're newly just getting off their substance, they're very fragile. They're living with other people. They're in a controlled environment, which is good for safety. We're giving them structure. But that impulse control, that they just can't go do what they want to do right when they want to do it, right? I'm a grown adult and you're telling me to go to class every day and you expect me to listen and pay attention. There's other people in the class that might be interrupting them. It's hard for them to say, hey, you know, he's going through a hard time too. Instead, they just impulsively blurt out in class or have an inability to regulate their emotions. That's a normal thing we see, okay? And you see this out in public, right? I think that's something too. When someone's intoxicated, you obviously don't behave like you should, right? Or that we would normally expect them to behave like. Understanding social situations, that's a big one too that we see in residential. It's hard for them to understand why you guys want me to do all these things, be attentive to class, and just dealing with other people in the treatment center or staff. That's a big one too. Limbic system, as we mentioned, this emotional memory is around the amygdala that I'm talking about. So when we experience that fight or flight, we also have that emotion. And that is right here. So this midbrain here, which are ventral tegmental area, which has the dopamine bodies that connects to all parts of the brain. Here's the hippocampus for memory, and here's the amygdala for emotional memory. So imagine how scary that is. Every time you use a substance, you're also storing that information in your memory and your emotional memory. So one of my first questions I ask when we've figured out which substance we want to focus on is, what's the age of first use and how are you introduced? They can't tell me who the last president was or anything else, but they can vividly tell me, I was 14 years old, I was with my group of friends, we're at their house, and my friend stole some alcohol, and that's the first time I drank. But can't tell me past presidents, anything else, and I'm like, okay. So to me, that's like storing that strong, deepened memory, because your brain remembered, and that dopamine response is stored now in your brain, and the emotional part. So I'm sure if you've ever been a young child and you smell smoke, and you see the fire alarm going off, your adrenaline spikes, you remember, right? I was afraid, I smelled smoke, our house caught on fire. Now as an adult, you smell some popcorn burning, it may trigger that same response, right? Hence, like with post-traumatic stress, right? That emotional memory is there. There's nothing attacking you, but whether it's a sound, a smell, another sensory thing, it can trigger it. So that whole thing is there to prevent you from getting hurt. It's there to protect yourself. But the scary part is it's also associated with the memory. So if they're having severe emotions of depression, anxiety, and now they use alcohol, we'll just use that as an example, they remember that feeling of, oh, it also took my emotion away. So not only do I have a stored physical memory of this, I also have an emotional linkage to it. So now this is where the brain's almost getting hijacked in that sense, that when I'm feeling these things, I'm experiencing this, my brain knows, I go get alcohol, it's going to increase my dopamine and take those feelings away. So that's where coping skills comes in a lot that we try to teach in class, but it's very difficult to break that because it's a stored memory, okay? We kind of went through this very quickly. So as we were talking about dopamine, in particular in that area, I kind of really like this slide coming up here. When we talk about that addicted brain, I don't like using that word, but a brain susceptible to substance use. If we look at, this example here, particularly with sexual intercourse, somebody has an orgasm, it returns back to baseline, okay? Unfortunately, when people are susceptible to substance use, this normal baseline doesn't happen, okay? Once they've experienced it, and now they have this addicted, kind of what we say, their baseline is kind of adjusted, and that's the first high. And they're kind of presumably always trying to feel that feeling again, but the problem is the crash down, okay? So I think that's a lot of the times we're dealing with the emptiness feelings, the withdrawals, the worsening depression, the worsening anxiety. That's this crash coming down. And we'll just use some simple numbers here, just for numerical sake. If we just say, like, my baseline is maybe 50. It's Friday, I was at work today. Maybe it's at 60 now because I get to hang out with you guys. I feel honored, it's cool, right? That's a great day. So now let's say I consume some chocolate, comfort food, right? My dopamine goes to 100, I've just doubled it. That's pretty good. Nicotine gets it to about 200, okay? Sexual intercourse, 200. Alcohol, which is not on here, can be anywhere from 400 to 600. Opiates can be about 600 to 800. And then cocaine can be anywhere around 800. Methamphetamine is 1,300. So for me to go from a baseline of 50 and then be coming all the way down from 1,300, imagine the barrage and roller coaster of emotional feeling I'm having, the physical dependency, the withdrawals, the psychological dependency, the worsening depression, negative thoughts, feeling of emptiness is the number one thing they say. I feel empty inside. I don't feel anything, no emotion at all. That's something that's very big on their first intake. And that's one of the hardest things to explain to them, that this is something you're gonna feel. And it's hard for people to understand what dopamine does, right? Without dopamine, we couldn't live. So essentially, we have dopamine for many reasons, physically and psychologically. But essentially, we have all dopamine to help us live. Dopamine teaches us at a young age to drink water, eat food, and sleep. As we hit adolescence, it teaches us to drink water, eat food, and procreate. We're all ingrained to do that, okay? But dopamine also teaches a lot of other things. That's where our drive comes from. So that's how our personality comes from. That's who we are, in a sense, if we keep it simple like that. But physically, what do we need it for? Simple muscle movements, right? Have you ever seen somebody with Parkinson's? They have something called cogwheel rigidity. They can't move normal because they're lacking dopamine. And we see in other examples when people have dopamine levels too high, those are signs of schizophrenia. That's a biological disease. Their brain's baseline dopamine level's too high. And they have the auditory and visual hallucinations, paranoid thoughts. That's the same thing what happens when people are using methamphetamines. So some of the symptoms very much overlap. So when we look at somebody with high dopamine levels, meaning that now that dopamine's increased and we're kind of not using our prefrontal cortex anymore, our brain has kind of been hijacked, and that's where we lose our impulse control. They can be aggressive, anxious, paranoid. Very common symptoms if you've ever seen anybody using methamphetamines and they're actively high. I recently did a talk with the police for their CIT training, and imagine approaching somebody like that and trying to help them when their perception of reality is totally changed. Hallucinations, we hear that a lot, auditory and visual hallucinations, delusions, paranoid thoughts, disrupted sleep, decreased motivation, and my example is a biological disease of schizophrenia. Baseline, that's what essentially you have. And on the opposite end of the spectrum, we have low dopamine. Behavioral issues, depression, anxiety, and sadness. As you can see, these overlap when you have depressed mood. Decreased concentration, poor short-term memory, forgetfulness, sleep disturbances on both sides. But this is that physical part. We see tremors, muscle tension, lack of coordination. And this can also be with alcohol, when they're going through alcohol withdrawal. But we see this a lot with methamphetamines. So this here is a brain. I don't believe in this slide that they're all the same person. A lot of people ask me that question. I don't think it's the same person. But it actually shows that recovery is possible. And that's the biggest thing I try to get to patients. You're just coming to us for 21 to 28 days. It is the worst week of your life. They literally have very little social support, no financial support, family or friends. A lot of them are involved in legal issues. And now they're coming to us and expecting us to help them. I could only imagine how somebody like that feels. And I try to tell them, you have to think of this as least minimum of a 1-year plan. And this is just the springboard part. This is just the start. That's why we have case management, we have social workers, we have everybody to help them to recreate this foundation. And I look at it for the next year. Obviously, we want them to be sober for a much longer period of time because this is a chronic illness. But I really tell them we got to focus on 30 days, 60 days, 90 days, a year, right? 6 months to a year. But you can see here that in a healthy brain, this part of the midbrain is pretty well lit up. Then we have this after a month of abstaining from methamphetamine, and this is after 14 months. So I tell people, you can gain some function back. You can get back to normal, right? So I think that's something important for them to understand because with that feeling of emptiness, it feels like it's never going to go away. That's one of the biggest things they say. I'm afraid I'm not going to feel anything ever again. And regardless of how many medications we can start them on, the brain is not just going to bounce back within a month, right? Like, it's just a reality. So here's that DSM-5 criteria before we get into that. I'm going kind of fast. But any questions? Anybody? Okay. So this DSM-5 criteria is pretty important. That's how we kind of judge where people belong, because we want to meet them at the level of their need. So over at Stepping Stone, we're a 3.5 facility, meaning that we don't take people like in severe detox, meaning we don't have a nurse or medical staff 24 hours a day. So if we look at like Deaconess Cross Point, Brentwood, they're a 4.0, 3.7. They can handle people in a lot more severe detox. And the concern for that is there's two types of withdrawals that'll kill you: alcohol and benzodiazepines. So that's why it's very important that we have them come and we utilize certain tools, CIWA, which is a score for alcohol withdrawal, and we use the COW score for opiate withdrawal. But it's very important for us to know that and get them in the right place for their just pure safety, right? We want to meet them at their level of care. So we look at our DSM-5 criteria, and I end up asking most of these questions throughout my intake, whether I directly ask them or I just ask them, tell me your story. You know, you started using marijuana at 14. Now you're 38, 42, whatever. Tell me how this has influenced your life, right? And it's very interesting when you hear about methamphetamine. It's like, oh, I just tried it socially, and then, I don't know, within a year I was using daily. And then you just get these cascade of problems. And this is kind of what, like, they almost answer all my questions for me. But we'll run through this real quick. First question we ask here is, are you using the substance longer than you intended to? It's like almost always a yes, right? Like, I'm at residential, what do you think? Trying to cut down or stop using it, but being unable to. Experience intense cravings. This is a new one. I believe that was recently added, I think in 2022 or 2023. Before, this one wasn't in here. And this one's very important. I'm glad they added it in here, because this also makes it a candidate if you're a candidate for the medicated assisted treatments, okay? So that's a very important one they added. Needing more time or needing more of the substance to get the desired effect. That's the tolerance we talk about. Again, part of the more physical dependence. Developing withdrawal substances, withdrawal symptoms when not using the substance. That to me, again, is a physical dependence. Spending more time getting and using drugs or recovering from the substance. So whether that's a hangover or they're experiencing withdrawals when they're not using it. Neglecting responsibilities, homeschool, work because of their substance use. That's a big one for me. Everybody has depression and anxiety, but how is it affecting your daily function? Are you able to function? Now you're giving up all your obligations, okay? Continuing to use even when it causes relationship issues, family, friends. Giving up, this is another one too, because I feel it links with depression. Giving up on social or recreational activities to go use your substance. Everybody thinks they're having a wild time and they're partying and everything. A lot of people are using alone and nobody knows about it. So if you guys know the PHQ-9 score for depression, what's the first question we ask? Any loss of interest in activities or hobbies? That's the number one question. So here, that's why I really link on this one a lot for me, because it's like, what do you do for fun? Or what did you used to do? I used to play instrument. I used to play guitar. I loved it. When was the last time I played guitar? I haven't played in years, you know? So to me, that now it's not only affecting their work, home, school, family, but also themselves. Using in a risky setting, intravenous drug use, right? I mean, it's just that easy. And then, can't see the bottom one, but is it affecting your physical or mental health? I mean, just in their whole story, a lot of people meet all of these criteria. So if we look here at level of severity, 1 symptom risky use, 2 to 3 mild, 4 to 5 moderate, greater than 6 severe. But I always tell them, look how soon you can get into remission. I think that's amazing. That's your goal. That's where I set them at. And then already in 1 year, you're in early remission. 1 to 5 years, you're in sustained. So even if 20 years of your life has been affected by using substance use, look how fast you can heal. And that's the part I try to get them focused on, especially in the residential. with my background playing sports, played collegiate football, you play a game, you watch your game film, right? And you learn from the mistakes you made. So I told them, this is your chance. This is like your mini boot camp for the rest of your life. You're getting 3 to 4 weeks to now sit in these classes, meet with your therapist, and I want you to go back, because I've never walked a mile in their shoes. I don't know what they're experiencing. So I said, I can't promise you every single class and group is going to connect with you. But I want you guys to think about all these triggers, your relapse prevention plan, who are those people in your life, what are those situations, what are those emotions, learn your coping skills, watch the game from your life backwards so we can move forward. So that's kind of like my big pitch to them on trying to keep them very engaged in class. But it's the truth. They've destroyed so much of their life that they spent so long building that now it's like, what do I do moving forward? I think the medicines honestly only work like 30, 40%, right? They're helpful, but I don't think there's a single medication out there that says if we give it to you, you're cured, right? You still have, even for high blood pressure, diabetes, you still have to learn how to count carbs, you still have to exercise, right? We have to do all those things in addition to being on medication. And that's the part that I really enjoy about being at Southwestern is we have such good programming for them. It's just a lot for them at first to take in. Imagine that first week when they're still getting off substances. So I think that's a crucial part to explain it to them in that way. So as I mentioned, we're at 3.5 low facility, residential inpatient. But we also have our PHP program. That's a 2.5 program. So people can kind of step down or they can step up. So that's something interesting too. A lot of people think, oh, I did residential, I graduated, and then a couple months later they have a minor lapse or they have a full relapse and they go, I already did residential, I want to go back again. And I'm like, well, I don't think you learned enough. Or maybe we can find a reason for you to come back to residential. Otherwise, we can step you down to partial hospitalization. That's a minimum of 20 hours a week where they come to the facility for programming, but they don't stay there overnight. And then obviously we have outpatient, which is what I'm also doing. That's a new program we started. So we have all levels of care at Stepping Stone, which is really cool. And as I mentioned here, these are kind of this is kind of the dimensions and subdimensions that I think come up with all that DSM-5 criteria. So minus that, we have kind of two ways I look at it. You have behavioral therapy, which is very important that they need, and we have the medications. So I think now, CBT, contingency management for methamphetamine use, is something a program I kind of want to get started over at Stepping Stone if we can. Motivational enhancement therapy, family therapy, all this stuff is very helpful. But this is my special stuff, and that's why I went and did fellowship, because I'm a big fan of this MAT, the medication-assisted treatment. Reason why I say that is we use, in medicine, we think about how effective a medication is, right? So we look at blood pressure medicine. We met 120 million people have high blood pressure. The medication lisinopril is a very commonly used medication. It's in the ACE inhibitor family. And it has about 1 in 65 numbers needed to treat to show effectiveness, right? That's a really good medicine. My mom takes it, I take it, and it works. But when we look at the medication Suboxone, which we're going to talk about, that's 1 in 10. To me, that's like the perfect locking key, that medication exactly does what it's intended to do, and it works, and it's very effective. And I think there's a lot of misconception about MAT, that we're replacing one apple for another. And I will agree with you in one circumstance. So we're going to start with opiates. So all these three are the FDA-approved medications, 3 for alcohol and 3 for opiates, okay? We're going to start with methadone. To me, that is kind of a trading one apple for another apple, okay? The reason why I say that is we're going to use some fancy terms, agonist, antagonist. Being in a theater, very Shakespearean, the agonist is the good guy. He's turning everything on. The antagonist, you can say, is the bad guy. He's blocking everything. So when we think about the receptors, those nucleus accumbens receptors in your brain, what is turning that receptor on and releasing dopamine? And that we're going to call the full agonist. And then we're going to talk about what's closing that receptor. We're going to call that antagonist. So methadone, if you look, is a full agonist. So how is that medicine, right? Opiates, Dilaudid, heroin, fentanyl, Percocet, roxicodone, oxycodone, all that stuff is also a full agonist. So how is this treatment? It's treatment because it prevents withdrawals. The only difference is most opiates have a shorter half-life. So if we look at most of our oral narcotics we use, they have a 6 to 8 hour half-life. That's why when you look at your prescription bottle, it says take 1 pill every 6 to 8 hours. Okay, that's its half-life. Fentanyl, unfortunately though, has a 72-hour half-life. Even though it's not actively working on the receptor, it's stored in our fat. It's a fat-soluble opiate. But methadone does the same thing. It has anywhere from a 24 to 100-hour half-life. And they have to dose every single day. And they generally have to go to a facility every single day. So how am I teaching them anything different? How am I restructuring their life? I'm telling you, no matter what, every day you have to go to this facility, regardless, hopefully they can earn enough to take it home on Sunday, right? Because it's not open. But all the holidays, 7 days a week, 6 days a week, they have to go to a facility every morning and get a dose of medication. How am I teaching them anything different? How am I teaching them how to live a normal life? I'm not. And unfortunately, methadone, in my opinion, is a very strong medication in the sense it has a 72-hour half-life and you're dosing every single day. You build up a high tolerance eventually to methadone. And that's why I think it doesn't work. Normal starting dose of methadone is anywhere from 30 to 40 milligrams within the first 3 to 5 days. They say the magic number is between 60 and 90, but I can't be on this for the next 20 years of my life, right? So eventually my body's going to get tolerant to it. That's that physical dependence we talked about. And then I have to increase my dose. Well, you can't because we have our guidelines and we don't want you essentially getting high now from it. But the problem is they can go home and use another opiate on top of methadone. So let's say they get some prescription pain pills from their friend or their partner. They can be on methadone and still use opiates on top. So because methadone has that long half-life, it still only works on pain for 6 to 10 hours. But the respiratory depression can last up to 24 hours. That's the scary thing about methadone. And that's why we don't use it at Southwestern. It's not a medication that we use there, but obviously there are some people that their disease is so severe that they have to use this, or they've already been on it. In order to get off methadone, it can be anywhere from a 7 to 10 to almost 14-day detox, which is extremely painful and uncomfortable for clients. So then we look at the complete opposite, which is naltrexone. So I don't like the way this slide is. So naloxone, naltrexone, those are both agonists. We know naloxone as Narcan. Naltrexone is just a longer acting version. So what's cool about naltrexone, it is just a complete blocker. So it goes to that site and just completely blocks it. So no opiate can get on. So generally we start this medication minimum of 72 hours or even 7 to 10 days after their last opiate use. And what's awesome about it, it comes in a pill or a shot, and you don't have withdrawals if you miss a dose. I think that's very important, that I don't want to be giving you medication that potentially can make you ill. So with methadone, if you do miss a dose, you will get sick. You'll have the withdrawal symptoms. With naltrexone, you don't, and I think that's very cool. And the fact that it's offered in a daily pill or it's offered in a monthly injection. Then we have Suboxone, which I know has created a lot of stigma in the community because people are viewing it as methadone. They're saying that, I am trading one apple for another apple. I said, that's true if you're using methadone because it's working on the receptors the same. It just has a longer half-life than the other medication. What's cool about Suboxone is it's a partial agonist-antagonist. So easiest way I can explain it, because if I can't explain it to my mom, I don't understand it. I tell her, have you ever been to the mall? It's a revolving door. Either that door is fully open, you can get on, and we'll say that's a full agonist, right? Full antagonist, that door is closed. I think the Suboxone working on the receptor, it's half open and half closed. So what's cool about it is that it helps with cravings and with withdrawals. But the other cool part of it, it has a peak effect. Meaning that if I'm on a full agonist, I can continue using and using and using and using. I don't hit any ceiling. Meaning I can take methadone, go home and use heroin right after. And that ceiling effect never happens. What's cool about Suboxone is you hit a ceiling. Meaning that right now at about, if you're using the 8 milligram film or tablet, using that twice a day, about a total of 16 milligrams, those receptor sites are 95% occupied. So it creates a ceiling effect where you can't essentially have an overdose or go use other opiates on top of it. And that's why I think this medication is different. The other good thing is you can taper them down. Off methadone, you can't taper them, you have to taper them up, right? Because over time, they're going to get tolerance and go through withdrawals. So that's why I find this medication very helpful. Because as their body and their brain starts to get rewired and kind of change, I can lower their dose over time. You can't do that with the other medication. And I guess that's another benefit of naltrexone. You never have to worry about that. You're on 50 milligrams or you get the shot once a month, right? But that's the cool part about Suboxone is that we can taper you down. And then there's also coming in a shot form called Sublocade. Comes in 2 formulations, 300 milligram, 100 milligrams. The cool thing about Sublocade is it has a 90-day half-life. So when the client says to me, it's been a year or 2 years, I've worked on all these other pillars of my life. I'm in therapy. My mental health is good. I reestablished my family. I'm working. And I think I have a really good grasp of everything right now. And I say, you know what? I think it's going to be great for you, and you want to get off of this medication. Awesome. Either they're already on the injection or we transition them to the injection. And what's cool is that medicine stays in your system for 90 days. So after their last dose of Sublocade, they're not going to have any withdrawal symptoms. Because as I mentioned before, Suboxone is a partial agonist, right? So they could have some withdrawal symptoms since it's about 12 to 24-hour half-life. But with Sublocade, it's a 90-day half-life. So they don't have any withdrawals, and it slowly leaves their body. I think that's very cool. That's very scientific-y, however you want to say it. That's like I said, it's a perfect locking key in my opinion. Most people on insulin or all these GLP-1 injections, it doesn't necessarily work the same, right? So naltrexone, as I mentioned before, is that complete antagonist. It just blocks the receptor. But then, so I find this very effective in alcohol use disorder. But then when we look at acamprosate, it similarly kind of works kind of like Suboxone does. The only issue is that you have to take 2 pills 3 times a day. Most people are already on a lot of medications as is. And then again, am I training their brain any different? You got to take this at 8 o'clock, 2 o'clock, and 8 o'clock every day. And now they're carrying a pill bottle around with them. I don't like that type of reinforcement. So sometimes I'm not a big fan of using this medication. But this is the oldest kind of, I wouldn't say the oldest, but a very popular one in the past was disulfiram, known as Antabuse. And what's so interesting about this one, it kind of works on a negative reinforcement. We have an enzyme in our liver called acetaldehyde dehydrogenase. And essentially this blocks that enzyme from converting the ethanol into acetaldehyde into acetone so we can get rid of it. So essentially you give this person alcohol poisoning. It can have up to a 72-hour half-life as well, meaning that if you took the pill on Tuesday and you drink on Saturday, you could still get sick. But with informed consent, I have to tell clients this can happen. I can't just surprise them and say, take this pill every day and just don't drink on it. Trust me, right? I have to tell them what the side effects are of the medication and if they drink. So it's very easy for them, though, to say, I just won't take the pill for 3-4 days, go drink at my cousin's wedding, wait 3-4 days later, and then I'll start back on the pill again. So personally, I don't think this is a very effective tool because, again, it's negative reinforcement. Interestingly enough, people of Asian ethnicity naturally lack this enzyme in their liver. So it's kind of where this whole science came from. I think that's why there's no drinking age minimum in China, because a lot of times they lack this enzyme, and those eventually end up with alcohol poisoning. So this is actually, as we were talking about genetics earlier, it's actually genetic, not a defect, they just happen to just lack that enzyme. So they can't metabolize alcohol the same as other ethnicities or backgrounds do. Any questions on these type of things? Go for it.
Do you have a standard taper for
It's kind of case by case. So the biggest thing I ask them is, once we get them started on a certain dose, meaning like let's say they just were using fentanyl, and I said, hey, I have to wait 3 days so we can start you on medication. So normally I believe in using a lot of comfort medications, things that they can just take as needed to help the symptoms of body aches, anxiety, stomach cramps, nausea, right? Restlessness, sleep. I like to use just as needed things for 3 to 5 days. And then we get them started on a relatively good dose. In my experience, just with what I've been using, it is okay to use up to 24 milligrams of fentanyl. That's the max dose, not fentanyl, Suboxone. That's the max dose in the United States. So if I tell them, hey, I'm going to start you on this higher dose, but you're not going to be on it forever, right? We just want to cover those withdrawals and craving symptoms. But then my goal is to taper them down, right? However long that takes. Some other organizations have a strict taper profile where we start everyone at a certain dose, and after 2-3 months, we bring you down by 6 to 8 milligrams, and then you're just off. To me, I don't think that's safe. I generally like to taper people down slowly, so either by 2 to 4 milligrams at a time. But my biggest question I ask them is, how long can you go in between doses? If you notice you take it in the morning, and if you miss your evening dose, you're already getting minor withdrawal symptoms. Sweaty palms, you're getting, restless, stomach issues, can't sleep. Now I'm kind of understanding the dependency that they had on the opiate. So they can tell me, hey, I took it in the morning and I just didn't take it till almost 10 o'clock at night again. I'm like, do we really need to be on this? Let's cut down your evening dose and let's see how you do. So generally I see them, if you're just coming to me from outpatient, at least my first 4 to 6 visits, I like to see you weekly. So they just get 7 days at a time. And then if everything's doing good, we have drug screens showing that they're taking the medication. Personally, I don't look at drug screens as a bad thing. Everybody uses these negative words like a drop or clean or dirty. I don't use any of those words. To me, I need to, one, know you're taking the medication I'm prescribing you. So we test for buprenorphine. And if something else does pop in the drug screen, this is my topic of conversation, right? I'm not here to slap your hand. I'm not here to punish you. I'm doing this to know, right? Which means this is going to change my encounter with you. Maybe now that you're on Suboxone, you might be craving something else. Or I noticed their nicotine cravings go up. That's the biggest one. In treatment, sugar and nicotine go up. Why? Because your body's missing that dopamine, right? So it's like, hey, you know what? I'm just going to throw a crazy idea out to you. Do you ever actually want to quit smoking? I actually do want to quit smoking, but I can't. Well, maybe we can deal with that too, right? So that's the one thing I didn't have on this slide is for nicotine cessation, we like to use either 3 long-acting with a short-acting. So long-acting, we look at the patch system. So step 1 is 21 milligram patch for like about a month, 14 milligram patch for the next month, 7 milligram patch. But we also give them something throughout the day, short-acting for like those breakthrough cravings, whether that's gum, the lozenge. I know they say you can use the nicotine inhaler or the e-cigarette, but a lot of insurance doesn't cover that. So commonly we use the gum or the lozenge, and that comes in 2 or 4 milligrams. And roughly 1 cigarette is 4 milligrams, right? So I'm like, well, if we can, see how much, let's start you on the patch, and we'll give you some breakthrough throughout the day, right? The other cool thing is you can use Wellbutrin, bupropion, the short-acting formula, and that's commonly prescribed as Zyban, right? We can use that for nicotine cessation as well. Benefit of that, it helps with anxiety and depression. And we can still give them that short-acting nicotine replacement of the gum and lozenge. The other medication is varenicline, known as Chantix. And there was a little bit of stigma about that. It had an increased rate of suicidality, but that was a very low percentage. I think it was like 0.1%. So I think it just got a bad rap at the beginning, but that medication works exactly like Suboxone does on the nicotine acetylcholine receptors in your brain. So it's also a partial agonist-antagonist. And the cool thing is generally clients can still smoke within the first 7 days, but their urge and their cravings tend to go away. So after 7 days, they are smoke-free. So I like to use that especially for people who, let's say, are having a lot of health issues. They're like, I need to go get a hip replacement, knee replacement, but I have to quit smoking 8 weeks before and after. I don't think I can do that. So I use that option of Chantix for them. And then generally, they don't even need the short-acting nicotine replacement. So those are the FDA-approved ones for nicotine. But yeah, I think definitely, depending where that person is, that's why I like Suboxone, because we can taper them down. Now, the one thing about it on that slide was there is buprenorphine only, and that's Subutex. And that initially was what they thought was safer to use in pregnant women. But buprenorphine monotherapy by itself is FDA approved for pain management. So if they were to go see a pain management doctor, they could be given a patch of buprenorphine that they wear once every 7 days. And that's a patch that's, I think, very helpful. So that medication is now being used. And when I did my fellowship in San Antonio, at the University of San Antonio, they actually use that in the VA a lot to get people off of opiates who have chronic pain. They use the buprenorphine patch. So some clients ask for that specifically, but I feel safer with Suboxone because we have that naloxone portion in it, right? So that's blocking any other opiate from coming on and knocking the buprenorphine off. So to me, it's just a safer option. But we do get that little added bit of pain benefit. But I very clearly make it clear to them, I'm not your pain management doctor. You have an opioid use disorder, and we're just happy to get an added benefit for pain. So that's why I think some clients, when they start getting off of opiates, now they start feeling all those things, right? And that's kind of like, oh, I like this Suboxone for that added benefit. Yes?
So, okay, I understand every patient, every case is different.
Mm-hmm.
What do you think is our ethical responsibility to patients? I know I've seen patients that are on NET for 5 to 10 days.
Absolutely.
How do we advocate with and sensitive to their needs?
Sure.
Each case for
Correct. So to me, I look at being on Suboxone as no different as any other medication, right? So do I want them to be on this medication forever? Not necessarily. But if you've used for 40 years, how do I know that your brain is not permanently changed, right? And I'm not going to be able to get you off of Suboxone, or I can get you to the lowest dose possible, right? And is it still providing a therapeutic benefit? So sometimes I wonder, now that you've been on this medication, have they put too much faith in the security blanket of the medication? And that's why I make it very clear to them, this is helping 30, 40%. I can't just have you come see me bi-weekly and monthly and not go to group, not go to AA, not see your therapist, and just say, oh, I need to go back to work because for so long I neglected my family and my bills. This medicine is going to save me. I tell them that, like I said, it's helping 30, 40%. People still relapse on Suboxone. And the issue is that you're opiate naive when you're taking Suboxone. So they think they're safe, and then they go back and maybe use what the amount they used to, and then they have an incident overdose. So to answer your question, it's kind of hard. But that's why I kind of do like that Sublocade option for them, that if you think you're going to be on this long term, I think it's safer that you get this monthly injection. And then we could actually attempt to get you off of this medication. I think their fear is going through withdrawals. That's their biggest fear, is I don't want to go through those things again because it's so uncomfortable. That's generally what I've noticed, is just a fear factor. You know, I have a client that I've been seeing for over 2 years. She's like on 2 milligrams and sometimes take half a milligram. I'm like, why are we still even doing this? I don't think this is doing anything for you. But I think she's kind of used it as a comfort. And she's just afraid that if there's a stressor, now that I'm getting older, if I have a health problem, are they going to prescribe me something? And I'm like, at this point, we just need to pick a weekend and we're going to cut this out. You don't need to be on this anymore. But there's nothing, I don't think I say wrong either being on it long term. It's just, do I need to have you on such a high dose? That's kind of my thing. But when we talk about something new moving forward, is that these GLP-1 medications have taken big favorability over the past few years for weight loss and diabetes. But what's cool and interesting about it is that These medications, so GLP-1 in your own body, what it does is it actually makes you fuller faster, so you get satiated quicker, right? By that, you're decreasing eating, so it helps regulate your blood sugar. It slows gastric emptying, right? So now when you eat, your stomach doesn't empty as fast. And it decreases glucagon. Glucagon is our hunger hormone. When you haven't eaten for a couple hours, your body secretes glucagon, and it goes to your liver, your body pumps out some sugar, and it tells your body, hey, get hungry, right? I'm hungry again. So that's what the GLP-1 does. But the interesting part about it is it also acts on this ventral tegmental area, as we were talking about the midbrain, and it's working on those cells, the nucleocumbent cells, for releasing dopamine. As I mentioned before, sugary foods, comfort foods, fried chicken, right, mac and cheese, hamburgers, all that stuff also secretes dopamine when we eat it. So these GLP-1s are not only mimicking anatomically in your stomach, but it's also having effects on your brain with decreasing the pleasure you feel from eating, especially overeaters or binge eating, right? So I think that part's interesting, is that some people say not only am I not as hungry, but the food isn't as palatable on my tongue and I don't enjoy eating it. Interesting thing enough is that people also notice they're not enjoying alcohol. Alcohol did not have the same effect on people using GLP-1s. So at the most recent ASAM conference, there was a big section on that is this medication now being studied for alcohol use disorder, which it is. So I can perceive see in the future that GLP-1s will also be FDA approved for alcohol use disorder. That is where I feel the research and literature is moving to, which points out even more so that this is a disease. And when we talk about people being on Suboxone for 10 years, how many people with diabetes are off their metformin? Right? That's what I really look at. Anyone with an A1C above 9, you're automatically eligible to be on insulin. Our goal is to optimize all your oral medications, right? But my mom is 83 and she's still on metformin. She never was insulin dependent, but she's had diabetes since she was 40. She is now on the lowest dose of metformin, 500 milligrams once a day. But prior to that, she was on Januvia, metformin, another diabetes oral medication, and now she's down to 1. So she's been on diabetes medication 40 years, right? So if I look at it as a chronic disease, is that really a bad thing, right? So she has very minimal long-term side effects from her diabetes because she eventually got it under control and it stayed under control. So I think this is very interesting, showing that to the public. MAT is no different. It's a treatment, right? GLP-1s have added benefits. This is a disease of the brain, and that this is a chronic illness that we have medications that are helpful. But I just want to take some of that stigma away that we're replacing that apple for another. Because the problem is with GLP-1s, when you get off, what happens? Everything goes back to normal again. So I think that's my last slide. Any other questions? Go for it.
Yeah, I have one. So I work at New Opportunities for Wellness,
Mhm.
outpatient, and I feel like recently not only have we seen more like severe mental illness,
Mhm.
but psychosis specifically. And so I think it's really hard when someone comes in to know, okay, is this someone who had a severe mental illness that is now abusing substances, or is this substance-induced severe mental illness?
Correct.
And we have a couple clients currently that it seems to be the latter, like
Mhm.
symptoms came in like 40s, like later in their life, and they're just not as receptive to medication intervention for their hallucinations.
Absolutely. So with now all this synthetic marijuana that's out there, a lot of the Delta variations, especially K2 spice, it's causing a lot of cannabis-induced psychosis. In my humble opinion, within the first 30 to 90 days of consuming a substance, can I really say you have schizophrenia? Can I really say you have bipolar? I don't know unless I get a good enough history from them that they said, no, I had these symptoms before, and these just exacerbated my symptoms.
I often ask, like, were you at least
right.
6 months sober when you got your diagnosis? And the answer has never been yes.
Correct, which makes it very difficult because we still acutely treat their symptoms with a lot of most commonly second-generation antipsychotics because they're safer. But when we were talking about that original slide about the adolescent use, the brain is not formed till 21. So there's a lot of literature out there showing that, especially with cannabis in adolescent boys, from that range of 15 to 25, adolescent to young adulthood, using cannabis at that age can manifest or bring out underlying psychiatric issues. So it wasn't very uncommon to see an 18 or 23-year-old being admitted to the hospital for cannabis-induced psychosis, even though he's only been experiencing a few years with marijuana.
I do a lot of psychoeducation on that, and I'm like the marijuana fun police, I ruined it. But it's very real. I guess my concern is I'm thinking of one client in particular, but I do believe it's substance-induced psychosis, and his medication regimen is just not touching.
Absolutely.
Is this it for him? Is he going to have auditory hallucinations for forever?
That potentially could be. I mean, especially with methamphetamine, depending on how much damage is done to the brain, they're resistant now to a lot of antipsychotics. But even when we look at just even, let's say, somebody on maybe who's not that far gone, their mind's that far gone, we'll say, but somebody who's taking, some SSRIs for depression or anxiety, and they're still using marijuana, I point out to them that our liver, right? We have all our liver enzymes. CY2A4 actually is what metabolizes cannabis, and it also metabolizes a lot of antipsychotics and SRIs. So I tell them that your mental health medications are not working because of your marijuana use. You're not even getting the full effect of these antidepressants or antipsychotics.
What's your typical response to that?
I never knew that, and I've been seeing a psychiatrist for years. No one ever told me that, right? And that's why now genetic testing with the oral swab is very big, right? So we can narrow down between all their liver enzymes, all the cytochrome P450s, and actually say your body can better metabolize these SSRIs, these antipsychotics, these anxiolytics. But then a lot of times they find out, which we recently had a client who found out he's genetically deficient in that enzyme. And he was using THC, but he's on an antipsychotic. And he says, and none of them work for me. But I said, but you've always been using THC, and you have a deficiency in that enzyme already. So the medication wasn't going to have a great effect in you from the start, but now you're using THC. What do you expect now? Maybe the medicine is only 25% effective.
Can you repeat what gene that is, and does it show up on the gene side? Because I'm not sure.
I've not actually looked at a recent gene size study, but there's cytochrome. It's 2A6 or it's 2A4, one of those, and then 3D6. If you look up just the actual, the numbers just slipped my mind. If you actually look up the cytochrome liver enzymes that metabolize THC and antidepressants, you'll get the ones that are linked. I'm pretty sure it's 2A4 and 3D6. Yep. So that's a big educational point I point out to them where they think it's green, it's from the ground, it's not going to hurt me. It's sold at all these head shops. They're okay. They're sold at gas stations. And then I have to explain to them that these synthetic variations can be more damaging than the alternative. Yeah. Absolutely. Any other questions? No? Awesome, guys. I hit it right on the hour.